So who will be the first begin?
You will be asked, doctor.
As doctor. I will be the doctor and Aiman will be the patient.
Yes.
Okay. And who will be the hospital? You?
I'm asking for the first grade doctor.
Okay. So I'm trying to concise the time. So Allah for 20 minutes for history, and then let us discuss the changes with you. Okay?
Okay.
Go ahead.
Okay. Bismillahirrahmanirrahim. Assalamualaikum.
Waalaikumsalam.
So can I know this is my lecturer and all my fellow friends. So I'll be clicking you and doing a physical examination a bit. Yeah, can I do that?
Yes, of course.
Yes. So can I know so today you brought your son or daughter?
Yeah, I have my son with me today. My name is Ramli.
Your name Ramli.
This is my son,
Okay.
Fitri.
Fitri.
He's currently 7 years old.
7 years old.
Yeah.
Okay. So so the so what's going on? So can you tell me what's the problem regarding your sons?
Actually, today I came for a follow-up. Fitri was admitted about a month ago to this hospital.
Okay.
And he was admitted for a few days, and then they've given us a date for him to come for a follow-up. They said that they want to take some kidney sample or something.
Oh, kidney sample. Okay. Does your son have any underlying disease?
He was currently he's 7 years old, so about 2 years ago he was diagnosed with this nephrotic syndrome.
Oh, nephrotic syndrome.
Mm-hmm.
When was he diagnosed having nephrotic syndrome?
He was diagnosed about 2 years ago when he was 5 years old.
2 years ago. Okay. So you coming here for, you said for taking a kidney sampling.
Yeah.
Okay.
It all started since last month, 1 month ago. Suddenly he had this facial swelling.
Oh, last month. So you come here because of what symptoms or your son's develops?
Currently he has no symptoms.
Okay.
He's a bit controlled.
Okay.
Because he came here for follow-up. But he got symptom. The reason we came to emergency was last month.
Oh, last month. Okay.
At that time, he woke up that morning. Suddenly, his mother noticed that his eyes were a bit smaller. Yes, and then she looks closer. It appears that his face was swollen all over.
Okay. So only swelling on that part, like in the eyes and the leg.
I think it's during the first day. Was the face, and yeah, it was the face only.
So the swelling happened for 1 month.
Not month after he was admitted, and then it was okay.
Currently, he's having any swelling?
No,
just last month.
Last month.
Okay. Any swelling in other area?
During the first day, it was only the face, and then we follow we adhere to the fluid restriction, and then just make sure he eats his medicine, and then we don't go to hospital on the first day. And then the next day, when he wakes up, we noticed that he had his abdomen become big.
So you came to the hospital on the second day of symptoms.
Yeah, on the second day.
So during that day, your son's having facial swelling, abdominal swelling, and also leg swelling.
Leg swelling also. But he's still active at that time.
Still active. Does he notice any reduce in the swelling throughout the 2 days of the episode?
No, it actually worsened.
Okay. So from facial leg swelling until abdominal swelling.
Yeah,
okay.
that's what
So
we
it
noticed.
become more generalized. Okay.
Yeah.
Does he having any pain on the swelling?
No, we didn't
And
complain.
any redness around the swelling?
No, we didn't notice any swelling, any redness, or he didn't complain any pain.
Okay. So on swelling on the leg, it is bilateral, right?
Yeah.
On the eyes also bilateral.
Yes.
Okay. Does you notice any facial puffiness?
Probably yeah. During the first day, his whole face is swollen.
Does your son having any itchiness around the swelling?
Itchiness? No. He deny any. He didn't say that he had any itchiness.
Prior to the symptoms, does your son like having any foods that causes the swelling?
Oh, you mean like allergy?
Yeah, allergy.
No, he's not allergic to any food.
Does your son like having insect bites on the swelling?
No, I didn't notice any insect bite.
Any trauma to the swelling like prior to the symptoms?
No, I don't think so.
I don't think so. Okay. You said that your son's having like abdominal swelling. Does your son complain of having abdominal pain?
No.
Any like constipations, diarrhea regarding the abdominal swelling?
No, during the symptom he was fine.
Yes. Okay. So that's regarding the swelling. About does he having any problem in urinations?
Urine, I noticed that during this the past few days before the admission, his urine became a bit dark.
A bit dark.
Like more concentrated in colours.
Or concentrated in colour, but it does not having like blood in the urine, like
No.
your son's urine become red.
No.
It's just become dark, like
Dark.
it's concentrated.
And it becomes more bubbly, frothy.
Frothy. Okay.
Yeah.
Does you notice your son's having like reduced urine output?
Yes, he has reduced urine.
Okay. Normally your son's having like, what is the frequency of your son's urine output?
I think if he drinks, maybe like 3
to 4 times. And during the episode, how many times?
less, 2.
Two times. So the symptoms on the urination, like darker urine, like reduced urine output, is happen same with the episode of the swelling.
Yeah, that's what I noticed.
Okay.
And at home we also do some dipstick test because he has an underlying nephrotic. And at that time, for the 2 days he had the symptom, it was 4 plus.
It was
4 protein.
Okay, 4 plus. So you on the second day you straight away go to the emergency department or stay?
Yeah, because it worsens.
Does your son having any like painful pain during urinations?
No, there's no pain.
During urinations. Like your son's having like smelly urine. You notice that, like smelly urine?
Like, is it become more smelly? Or
no, like you just urinate and you like smelling.
I think it's normal.
Okay. Does your son's having like problem in urination, like cannot your son's cannot urinate?
No, I think he urine.
Your son's complain of having pain on the loin?
No, he didn't say any pain or whatsoever.
Okay. Okay. How about your son's does your son's having any fever?
No.
No fever.
No fever.
No fever. Your son's having like any shortness of breath or rapid breathing?
No.
No rapid breathing, no shortness of breath. And also does your son's having like chest pain?
No. No pain at all.
Does your son like you said that your son having experience of swelling, like you notice that her weight is become more, or
his weight? I think his weight a bit increased. His pants become a bit tighter, but not sure how much he gained.
Any other, like your son's having like vomiting?
No.
No vomitings, no diarrhea, no There were no constipations.
No, he eats fine and he didn't vomit bad food.
And also your son's like having any drowsiness, like loss of consciousness during the episodes?
No.
No. Okay. So your son is still active regardless of the symptoms, or
Yeah.
okay. Does your son having like loss of appetite,
No, he eats.
like loss of weight?
So wait, now he gained a bit, I think.
Okay. Your son's having cough or
No.
no cough? Hemoptysis, like night sweat, sore throat or runny nose?
Hemoptysis.
No cough, so I don't ask that. Any night sweat?
Night sweat, I think. Yeah, if he. Yeah, this days is kind of hot, so
Okay.
he sweats a bit.
Does your son's like you said that your son's having nephrotic syndrome, right?
Yeah.
Yeah, nephrotic syndrome. So diagnosed 2 years ago during he was 5 years old. So currently, what medication that he used?
He was since.
Do you remember it?
There's some kind of steroid medication, I think.
Steroid medication. Do you know what's the exact name of the steroid?
Predni something.
Prednisolone.
Prednisolone.
Do you remember the dose of the steroid? 60 milligram or 40 milligram?
Wait, I think it's. I don't remember.
This is currently or not remember. Any other drugs?
He's on antibiotic.
On antibiotics.
Uh-uh.
Currently.
Currently.
Do you remember what's antibiotic?
Penicillin.
Penicillin.
And he is also is on fluid restriction. He can only drink like small mineral bottle.
This is in current situation, right?
Yeah.
Since one month ago, the doctor give the prednisolone, the antibiotics, and also the restriction of fluid. Okay.
Yeah.
We go back retrogradely. 2 years ago, since he was first diagnosed, do you remember how was the complaint?
It has generalized.
Or same episode like this one?
Yeah, similar.
And do you he was admitted, right?
He was admitted
For how many days?
We went to ED.
Okay.
And then when arrived at ED, he suddenly got headache.
Okay.
On top of his body swelling, his face swelling whatsoever. And then he was given some IV protein, albumin,
IV protein.
and also some steroid at that time in ED.
Okay.
And then after he was stable, he was admitted to pediatric ICU for 2 days.
ICU for 2 days.
And then after 2 days, he was transferred up to the normal pediatric ward.
Okay.
I'm sorry. For the steroid, he was given since he was diagnosed. After he was discharged, he was given steroid.
So since he was discharged, he was diagnosed with steroid also. Only steroid.
He was given at that time steroid.
Do you remember the dosage?
No, I don't remember the
Remember
dosage. Steroid and what's it? Fluid restriction.
Fluid restriction. Same 500 cc also. Similar. Or you did not remember? Okay. Does your son like you notice? Your son is on steroid. Does you notice that he's having like moon faces?
Like big face.
Like big face.
No, I don't
Like apa ni? Like thin extremities. Like
no,
proximal. No. Like do you notice like he's having like striae?
like lines.
Like lines on the abdomen.
No.
And then you notice like any humps on the back.
No, he's fine.
It's fine. So she was since he was diagnosed, he was on follow up in HTA also.
Follow up at KK Besar.
At KK Besar. So how frequent was his follow up?
His follow up is quite frequent. Since he was diagnosed, his follow up twice per week.
Twice per week.
Twice per week.
So this is like okay. This is like since he was diagnosed, how many times does he admitted for this reason for his nephrotic syndrome? How many times was?
I think about 7 like that.
7 since 2 years ago. Do you remember the exact time of the 7?
I don't remember. But the last one 1 month ago.
Okay, but for this current 6 months, how many times does he was admitted?
I think for this current 6 months, twice.
It's twice. So the doctors still giving you the steroid.
Yeah, they tried to reduce the dosage.
Okay, they try to reduce the dosage.
Whenever they try to reduce it, the symptoms came back.
Okay. Since he was diagnosed, he was given prednisolone. On the first month, do you notice that any improvement to your sons, like his urine? Your doctor asked you to do the urine dipstick, right? Do you notice that the urine dipstick is having low protein, like no protein,
I think
like less than 2 plus?
I think the lowest go is 2.
2 lah. Okay. So he's not improving regardless of the first time he's on prednisolone.
Seems so.
Okay. And the doctor still diagnose the doctor still prescribe same prednisolone.
Yeah.
Does the doctor like ask you to like advise you to prescribe you like other than steroid?
So far this time, no, I don't think so.
Oh, so whenever your son's having the same presentation, your doctor will just prescribe the prednisolone again.
I think continue the medication.
Okay. Okay. So that's for I want to ask regarding the immunization. So does your son like taking immunization up to his date, like taking all the
completed
all
the vaccination
up to his age? Regarding immunization, okay. Regarding her birth history, during her mother's pregnancy, does her mother like having problem during her pregnancy, like during the pregnancy, that like your like your wife, right? Your wife like having any underlying medical illness?
My wife was okay at the time, but Fitri, he was born at preterm, at 32 weeks.
Oh, preterm, like.
And he was born via surgery.
Oh, like cesarean section.
Emergency surgery. Because at that time my wife had contraction.
Oh, like a preterm contraction, like.
I think
so. Do you know what's the reason why? Due to preterm contraction, like your wife during the pregnancy, like during her giving birth, like your wife like having any underlying medical, like diabetes mellitus during pregnancy, like
no,
like hypertension?
No, she was fine then.
She was fine. Okay. So do you know what's your son's birth weight during that time?
About 2 kilogram.
2 kilogram. Okay. So he was admitted to NICU after due to the preterm contraction.
He was admitted to NICU for about 3 weeks.
For 3 weeks. Okay. Then it was okay after that.
Yeah, okay. He was given oxygen also in the ICU.
Oh, okay. After that, your son like having no problems and no complications.
Yeah, he grew up healthy until the diagnosis 2 years ago.
Okay. Regarding his development and growth, so how about his gross motor? Like he was able to walk right now?
Yeah. He can walk,
running, climbing.
He's an active kid.
Oh, jumping.
Yeah, he plays a lot. Walk up, downstairs, jump everywhere.
Even with the symptoms, he's like active like that.
Yeah, a bit active.
Okay. How about his like his writing, like alphabet and numbers?
Yeah, he can write.
He can write. Okay. And also he can groom himself, like dress himself.
Yes.
Okay. About his speech, does he like can talk, like understand what's instruction you're given? Okay. Yes. And also he responds during using a verbal response, like appropriate. Okay.
He talks.
So currently he's in school, right?
Pardon?
He's in school right now.
He's in school.
Primary school, right?
He just started primary school.
7 years. Oh, it's standard one, right?
Yeah.
In what school?
SK Bersera.
Oh, Sekolah Kebangsaan Bersera. So how about his academic performance, like his exam?
Recently, his academic was kind of poor because of the illness.
So does he usually like absent during school due to the illness?
He had multiple follow-up. His follow-up frequent, and then he had whenever the symptom occurs, he had admitted, and then he got MC.
Okay. So for his nutrition, He's now like taking adult food like rice, meat, and fish.
Yeah, he can already eat like me.
Does he's a picky eater?
Kinda quite picky.
But picky, how can you explain what that?
He don't like to eat vegetable that much.
Oh,
And certain type of fish he don't want to eat.
okay. So for a day, how many meals does he take?
About 2.
2 meals a day. 2. Like during what time during that day? Usually it's like 3 meals per day.
Oh, I think
Does he always skip meal?
No, he don't usually skip. He sometimes he requests to eat, even though he's a picky eater, but he eats. I think in morning and then lunch. Sometimes after going back from school, and then dinner. Sometimes he join up for dinner.
Oh,
If
so
he's feel full, he don't join.
or 2 to 3 times lah. Okay. So
1 minute.
does he exclusively breastfeed
Until
until what month?
since he was admitted to the NICU, he never breastfed because
He never breastfed. Can I know what's the reason?
I'm not sure, but since he was admitted to NICU, he was given formula milk, and I think my wife can produce so much milk. I think that's the reason.
Okay.
It's the same for most of our kids.
I want to ask about family history. Does her other family like having similar symptoms like him?
My wife, her mother has.
Oh, her mother's having nephrotic syndrome also.
It's not nephrotic syndrome. It's something called lupus.
Systemic lupus erythematosus.
Yeah.
Oh, okay. So her mother's having SLE.
Yeah.
Do you know his mother diagnosed when the SLE?
She told me that it was during 3 years old when
during
she was
childhood.
very little.
So currently it's on treatment. She's
Yeah.
on treatment.
She's on steroid,
On steroid also.
and she also had done the kidney
Oh,
sample.
the kidney sample. Oh, the same procedure like
Yeah.
your son. Okay.
But that's when she was little and her last attack of the lupus, the SLE, about 3 years ago.
3 years ago.
And her sister, I mean
Her auntie. Her aunt. Sorry.
Fitri's aunt,
Yeah.
my wife's sister, she also has this same disease as him, nephrotic.
Oh, nephrotic also.
Yeah.
It's not SLE.
It's not SLE. I think some that protein in the urine.
Okay. Oh. Regarding his sibling, does his sibling have the same presentation also?
No, all of his siblings are healthy.
How many siblings does he have?
He had 4 siblings. He is the 3rd child.
Sibling is the third one. Okay. So the other sibling is okay.
Yeah, they're all healthy.
So where do you live?
We live in Basra.
In Basra. In like having a basic amenities in the home.
Yeah, everything.
So can I know what's your household income?
About 4,000 per month.
About 4,000, including your wife.
My wife is a housewife. She doesn't work. I'm a technician at TM.
Technician. So I'm sorry. Can I ask you something like very bit sensitive? Like, do you smoke?
Yeah, I smoke.
I smoke. So how many per day do you smoke?
About 1 pack a day.
1 pack. So if you're smoking, you are smoking in front of your families or in front of them, or
I try avoid smoking.
so you're smoking away from
them.
Okay, thank you.
Okay.
Good scenario. It is helpful to have a doctor as a patient.
Okay, sorry.
Now you are going to give me summary, please, first.
Yeah, the summary.
Yes.
Summary or full presentation?
No, summary.
Summary, okay.
I
So
think we are happy to listen to this.
okay. Bismillah. So my patient, Fitri, a 7 years old Malay boy with underlying nephrotic syndrome, presented to Hospital Tengku Abu Altan for further investigation regarding her sudden onset of his facial onset of facial swelling, periorbital edema, and abdominal distension. since 1 month ago. There was also reduced in urine output, darker and frothy urine with the proteinuria in home like 4+. He was active and not lethargy. There were no symptoms of urinary tract infection, heart failure, liver failure, and also he's having a very strong family history like of nephrotic syndrome and systemic lupus erythematosus. Like his mother is having SLE, and his aunt is having nephrotic syndromes. Okay. Otherwise, he's having no fever, no cough, no sore throats, no respiratory symptoms, also no cardiology symptoms, and also no abdominal gastrointestinal symptoms.
Okay, so what is your working diagnosis?
So my working diagnosis is fluid overload secondary to relapsed nephrotic syndrome. That's my provisional diagnosis. So 0.4 because currently he's having underlying nephrotic syndrome since 2 years ago, and he's presented with generalized swelling, generalized edema, and is also having proteinuria, and have a very strong family history of nephrotic syndrome and also SLE. Okay. So for my differential diagnosis, so I would like to consider acute glomerular nephritis. So 0.4, he is having like generalized edema, and also he's having like reduced urine output, and also proteinuria, and also he's having a darker urine. However, I would like to confirm in urinalysis whether it is a darker urine or having like hematuria. So I would like to investigate that. Otherwise, points again like he's. Oh, I forgot to ask whether he's having like history of sore throats, having like post-streptococcal infections, and also I would like to further investigate in the physical exam whether he's having like hypertension or not. So another differential diagnosis that I would like to mention also fluid overload secondary to heart failure, because patient is having like generalized swelling, abdominal distensions, ascites, and also leg edema. However, patient did not really having like underlying heart disease, and also patient did not come with heart failure symptoms such as chest pain, shortness of breath. Okay. And also I would like to also to consider fluid overload secondary to liver failure because patients having edema and ascites. However, patients did not I did not ask about whether patients having jaundice, yellowish discoloration, or having like pruritus. Sorry about that. And also I would like to also consider patients having malnutrition. However, because his father said that he's having 2 meals per day, not like a usual normal per day, but I would like to investigate further regarding that. Okay, that's my working diagnosis.
So what investigation you would consider?
So for investigation, I would like to divide into bedside investigation, laboratory investigation, and also imaging. So for bedside investigation, I would like to do ECG, because one of our differential diagnosis is heart failure. So I would to check whether he's having heart problems, and also I would like to do the 24-hour urine protein, to know whether this patient having proteinuria or not. Also, for blood investigations, I would like to do full blood count to know whether this patient is having like infections or not, and I would like to do a liver function test to know whether this fluid overload is secondary to the liver failure, and also I would like to know the albumin, the blood serum albumin level, because patients in nephrotic syndromes are having a hypoalbuminemia, and also I would like to do this to do the serum cholesterol level, because patients in nephrotic syndrome might have a very high cholesterol level, and also I would like to do the serum complement level, C3 and C4, because patients like having strong family history of SLE, so patient might this nephrotic syndrome might due to the secondary cause of the nephrotic syndrome, so might be caused by systemic lupus erythematosus. So if that so the C3 and the C4 level will be low, and also I would like to do the um, the immunological investigations, such as to do the anti serum complement, anti double stranded DNA, and also the anti nuclear antibody. And also I would like to do the ASOT titers, because I would like to rule out for the post-trap glomerulonephritis. And also I would like to do the urinalysis, of course, to know whether patient is having hematuria or not, and also to know the protein level. And also I would like to do the renal profile to see whether this patient is having kidney injury or not.
What is the indication for kidney biopsy?
Indications. So the kidney renal biopsy is indicated when this patient is having steroid resistance nephrotic syndromes, which defined as when the patients did not achieve remissions within the first week of prednisolone treatment.
So this is the single indication?
No.
I think the patient can help you. You came today for kidney biopsy?
Yes, he came for renal biopsy.
Yes.
So what is the indication for kidney biopsy? He informed you that he's coming for kidney biopsy. So you make a very big trip around the egg and forget why he's coming to you. What is the indication for kidney biopsy?
Indication for renal biopsy, steroid resistance.
Hematuria.
Yes.
Gross
hematuria. What else?
Hypertension.
Hypertension.
And abnormal renal profile.
Renal profile. Okay.
Low coffee count.
Okay. You see, now we have at least 5 or 6 indications.
Okay.
And now you are in a time you must be ready. 1 to 3 or 5. Not accepted to say to kill one and what is the second, what is the third, or the fourth. I see that you have a good knowledge, and you know, you can pick the line, and it is very important. You can pick the line about the diagnosis and the possibility of differential diagnosis. So your history looks like directive, and it is very important. But you need to put some, I know this patient is your colleague, you need to put some soft touch with the patient. Don't do it like mechanical.
Oh,
So sorry, what is like that? So even soft work with the patient,
it will help to release his tension. Okay? So don't be hurry until you forgot to be sympathized with the patient. Any patient to come to you, he is in a weak situation. So you must be sympathized, please. This is number one. Number two, he already came to the clinic with established diagnosis. You can be natural. I mean, if you are doing like normal, it is very good. I remembered one of our colleagues, he entered the membership examination with us, and he can bypass. In spite, he said about 10 times, I don't know, but I will do like that. Asked him if you break by needle while you are doing operation or giving injection, what is the probability to get it? He told him it is very low, but I cannot remember the number. I'm going to search the net for that. Then he asked another question. He told him this a very serious point. I may ask my colleague, senior colleague. No problem. He considered that his way of thinking is natural. All of us are doing like that. Okay? So please, you can open the computer in front of you and check the detail, because the patient, whatever, even if he is a doctor, he will not oriented like you as a true treating physician. let me revise the notes inside the computer, because he give you a scenario that is coming to you for follow-up. Usually, if you have patient for follow-up, you must do that. So try to concentrate at this point. He has nephrotic syndrome diagnosed and coming for kidney biopsy. It's good to ask about other possibilities, but you didn't touch it. Very important blood pressure, very important detergent kidney function. You didn't put it in your differential diagnosis. You spoke about heart failure, liver failure, okay? But you didn't mention, you mentioned it hopefully while you are asking for kidney function test at the end, not at the start. And even when you start by investigation, you offer ECG to see if there is heart failure or not. No, we offer bedside test is urine, number one. And you must comment not only for albumin, for red cell casts, for hematuria, what is the color of the urine, okay? You didn't touch the one of the criteria of nephrotic syndrome. It's 4 component, yes? Number one is?
Proteinuria, heavy proteinuria.
Okay.
Edema,
Hyperlipidemia.
hyperlipidemia,
So
hyperlipidemia.
to liver function test, you must inform about cholesterol level and the lipid profile. It is very important because it is one of the problematic issue for the patient. He can go thrombosis and a lot of problems. So please take care about that. Another point, you asked about immunization, and it is a good point, but I need to ask the father of the patient, is there any limitation for immunization during high dose steroid or not?
Ada tak?
Any limitation or regulation for use for giving vaccination during high dose steroid courses?
Yes.
Yes. What is this limitation?
Limitation. Dia tak boleh cannot give life attenuated.
I think life attenuated vaccine.
Yes, it's very important. So he has now he's 7 years and he started at 5. And as you know, sometimes there is booster dose of vaccine can be given at the school entrance. So you must take care about that and put it in your background always. Now it is a few weeks or few months and you will be responsible for patient. Any patient under high dose steroid, immune suppressive drugs, given IVIG, you must take care about the guidelines for vaccination at that time. Okay. A good point that he informed you about complication of prematurity. Who else can answer the complication of prematurity? Just yes.
The most common complication for prematurity, we can divide it into system, which is for the cardiovascular system. The most common one is congenital heart disease. It could be acyanotic and also cyanotic congenital heart disease. And then for the respiratory, it can be
no. Sorry. Is there any intimate relation between congenital heart disease and the prematurity? To be cyanotic or acyanotic? No, it is mainly BDA for premature. Okay.
Not the most common one, PDA.
Yes. Okay. What else?
And then for the respiratory, respiratory distress syndrome, RDS.
Okay.
And then for
what else? Stay in the respiratory because it is the most challenging system for premature.
Persistent pulmonary hypertension.
Yeah, can be BPHN. What else? Very important. Another one. If someone doesn't adjust the FiO2, is giving. Yeah, can acute complication. No, I am asking for chronic complication. If you give this neonate and offer him high dose of oxygen, like starting by 100%, 80%.
Is it retinopathy of prematurity?
Okay, this one can yes,
Bronchopulmonary.
chronic lung disease or bronchopulmonary dysplasia. So we can harm while you are thinking you are giving a benefit, because free radical will come from oxygen, and it cause a lot of problem for the eye, for the chest. So you can get chronic lung disease, and this one is very bad, really. Okay. What other complication of prematurity? We said we speak about the eye, ROP, retinopathy of premature.
For the gastrointestinal, can be
Yes.
enterocolitis.
Okay, by NEC, feeding intolerance.
For the GERD also.
Okay.
Gastroesophageal reflux disease.
Okay, what about the brain?
Intraventricular.
Yeah, intraventricular hemorrhage and periventricular leukomalacia. Must able to differentiate between both of them. Of course, growth and the development will be affected. Okay. What else?
For hematological, it is anemia of prematurity.
Okay, anemia and apnea. Okay, what else? Very, very important. This patient is susceptible to gut infection. So the infection either through the maternal cause, if the mother has premature rupture or chorioamnionitis, or through our breaking uncontrolled infection like that. Okay, so it is very important to know about that for neonates. Who is going to give us the OSCE?
That would be me, doctor.
Doctor, may I ask a question?
Yes, of course.
Doctor, may I know regarding the hypercholesterolemia in nephrotic patient, do they have a higher risk also to develop coronary arterial disease, or they will not go to that extent?
Really, they are speaking more about thrombosis, but if you ask theoretically can, but I think that the children heart, it has no other problem, and the fluid overload is not so high. We didn't use it to see it, but let us revise. The most common one is the thrombotic. I would like to remember you also about the pedigree, family pedigree. At the time, I think it is better to ask to try to draw the family. Okay, how old are you? How is about your wife? What about your kids? One by one, what your brother, your sister, your father, your mother. So family pedigree will save your time and save your neck also. Okay. Another thing I asked you, you can go through the computer. We have everything in the computer. You can revise. You just offer that. I am going to revise the case of the computer just a while like that. Also, we have lookbook with the patient. If the patient came to the clinic, usually he will enter the clinic with his lookbook. You can ask him, do you have the lookbook? Can I know some details? The other important thing for you, please, my son, future doctor, I think a challenge here was not the differential diagnosis. Can you understand me? Your challenge here is the details of the diagnosis itself. Hello? Can you hear me?
Yes.
I told you before, any disease has root and fruit. You remember this one, yes?
Yes,
this disease, which is nephrotic syndrome, I must define. Is it he got twice for the last 6 months. So what is the diagnosis now? Is it just a simple nephrotic?
Relapse.
Frequent relapse nephrotic syndrome. It's very important. So now I can put one more bonus for the diagnosis. Number two, there is strong family history of SLE and like that. So I can put the cause here with possible secondary to autoimmune disease like SLE, because sometimes it is not SLE alone. You didn't see it, maybe some other autoimmune disease, mixed picture. And what is the complication? You must be able to speak about that. Okay, you asked good about the Cushing syndrome, but you didn't ask like acute peritonitis, okay, any thrombosis, like that. So you must concentrate at this situation about the detail of the diagnosis itself. Is it frequent relapsing, nephrotic syndrome in need of renal biopsy? We need to rule out other autoimmune diseases and search for complication which can happen for the child, like failure of growth, like Cushing syndrome, like that. Okay, it is very important here to concentrate in the disease. Okay, of course, you may be very diplomatic and say, if I saw this patient in the first time, I'm going to consider other important differential diagnoses related to the heart, related to the liver, like that. Okay. Thank you. Let us see the slides now.
We cannot see the slide, Afieqah.
Yeah, the title.
We can see it. I can see it.
I still cannot see the slide.
Okay dah. Tapi tak full. Okay, dah.
Okay, is everybody ready? It's quite simple.
Yes.
So Afieqah, can you just move on to the next slide? So can somebody tell me what this is?
Periorbital edema.
No. Okay. And? Facial puffiness as well.
Okay.
Next. This?
Quarter swelling.
Or?
Labial
in girls, it will be labial swelling, yes. This one?
Ascites.
Ascites. So in cases of ascites, the child can present with or have a risk of?
SBP.
Yes. And they can present with what type of breathing? Any sort of respiratory distress?
Labored breathing?
Yeah, because if they have ascites, there can be mechanical obstruction. So they can have shortness of breath, or they can, if the ascites is actually worsened, I did not put a slide of this, but they can actually also have pulmonary edema. And then they'll present with shortness of breathing as well and some sort of respiratory distress. Next.
Really, this slide, please come back to this slide. For me, if I see this slide, I must put my differential diagnosis kwashiorkor, protein caloric malnutrition, because he looks beefish, his hair looks sparse and slightly brownish like that, and his abdomen is distended, and his upper limb looks slightly not so emaciated. But sometimes we must consider in the differential diagnosis of the picture alone, we can put also protein caloric malnutrition. Okay.
Okay, I didn't think of that.
And please, we better also to be very accurate. You cannot look at this slide and say it is ascites. If it is abdominal distension, and the abdominal distension can be 5F, okay, fluid or fetus or what about, you remember that? Most probably it is ascites. It is ascites, okay? Good. Okay.
Next. This?
Pedal edema.
No, not enough to say pedal edema. What you must say? Beating. Yeah. It is very important.
Bilateral.
The characteristic pedal edema is one of the characteristic of edema here. Okay.
This?
Forty urine.
Indicating?
Proteinuria.
Yes.
How many? 1 plus, 2 plus, 3 plus?
I'm not sure about that. I got this on the internet.
You must know that because you are going to teach the patients. Okay, just in the first chance, you just read what written over the kids.
Okay, so this is for routine urine examination. So just the values will come up, but I want somebody to try to guess the color of the urine and maybe the albumin levels.
So in nephrotic, the color can be normal.
Okay.
Normal color. Albumin will be high.
Okay. Can there be presence of red blood cells?
Yeah, but not usual.
Okay, that's good. Can you click? Yes. So the color, as she said, can be normal, which we can describe as straw. And then for albumin levels, because there is proteinuria, so there will be albumin in the urine. So it will be plus. There will be a plus actually. There will be a lot of albumin. RBCs, microhematuria can be present or can be not present, but it's usually not present in nephrotic syndrome. And if you culture the urine, there will be no growth unless they have UTI. Next, please. So this is just a hemogram, which is their full blood count. Their hemoglobin and ESR can be normal. White blood count can be raised if they have an infection, an ongoing infection. In this case, it wasn't, because I got this from a case of pure relapse, the nephrotic syndrome. Next.
So again, no, please. Hemoglobin 10 is acceptable. What is the definition of anemia?
It depends on where you get it, but below 13.
Below for children below 11.5. Okay, so this is our cut point. So do you feel that this patient has anemia?
Yes.
Yes, can be, but sometimes it is dilutional. I mean, if the edema is so high, it can give us false prediction. That's why we need to look for the hematocrit.
Okay.
It will help. Second one is ESR 125 millimeter in the first hour. Is it normal? What is the normal for ESR? Who can answer?
30, 35?
20, yes. 20, like that, not more like this. So it is very important. What about the total white count? For 3 years, I think it's high also, slightly high. Okay, so you must take care about interpretation of the full blood count. I used it to advise all staff to make a good revision about how to interpret full blood count, because really it is the most common test used, but most of the time we are not using it wisely. So if you need to, someone of you can just write how to interpret RPCs and put it to the group, but go for every parameter and decide how we can make use of that, okay? And you can send it to the group. Let me see it, inshallah.
Okay.
Don't forget, okay? Go ahead.
So these are the biochemical parameters for important to see the serum albumin as well as the serum creatinine. In this case, the serum albumin is 7.5, but this is in in GM per DL. If I'm not mistaken, the one I found is that it's supposed to be 3.4 to 5.4. So in this case,
you need to ask us what is wrong, what's correct, or what's your plan?
yes, I want somebody to interpret this.
Okay.
But,
you have 10 somebodies who will answer.
Somebody? Is anybody going to volunteer?
Don't worry, I will choose for you. If no one raises his hand, I will choose. Aliyah? Aliyah?
Yes, doctor.
Please comment about this one. Is it normal or abnormal? And if it is nephrotic, what did you suspect to be the difference?
So for nephrotic, the serum albumin will be low.
Yes.
So for this case, sorry, doctor, I don't remember the lab value.
Okay, but what about urea and creatinine? Usually it is normal, unless
usually it will be normal unless there is a renal failure or
acute,
any acute kidney injury secondary to any infection like that.
not infection. For this situation, it is a lot of causes. Okay, albumin is usually low.
Low.
What about electrolytes?
Electrolyte.
Slightly hypokalemia.
Why?
Because less than 3.5. Normal is 3.5 to 5.5.
Okay, so it is a borderline. It's borderline hypokalemia, but take care that hypokalemia and hyperkalemia are considered medical emergencies. Okay. What about the liver function test? You must ask also for the lipid profile as a part of liver function test, which suspected to be high. Okay. C-reactive protein we cannot comment because it depends on the lab, in the result of the lab. Sometimes the kits make the normal, like our hospital, less than 0.5. Some hospital less than 5. Some other hospital less than 10. So it depends upon the kits at the end. Do you need Dua? Do you need to add anything, Dua?
The liver profile, as you said, but I didn't find that for this case.
What is SGPT?
I don't know. SGPT is the same, I think, for AST.
Okay, AST and ALT, or SGOT and SGIPT.
Yeah, so SGPT will be the ALT. SGOT is AST.
Okay.
So the normal is up to 56.
If it is ALT, I think it's less than that, around 30s like that. But I would like to add here important point, which is secondary nephrotic syndrome can be to autoimmune disease like SLE, can be due to infection like hepatitis.
Oh,
and the
super
HIV
beautiful.
and the HIV. That's why sometimes if we suspect any immune deficiency, we are going to ask for HIV, we ask for hepatitis. It is very important.
Okay.
Okay. Second slide, please.
So this is a slide just to show the changes at the basement membrane. Can anybody try to explain the slide or see the differences between the two pictures, which is B and C?
From what I understand from the picture, so we can see that between B and C. So for the B, we can see clearly the podocyte, which is in V line, like in like what is called, like it is like a V line structure.
Mm-hmm.
However, in C, the podocyte, it seems like that it becomes like effacement of the podocyte.
You can see that it's marked P.
Yeah.
Yeah, okay. Keep going.
Okay. So and then I can see from like this is like glomerulus. So it consists of that three layer, which is podocyte, glomerular basement membrane, and also the third layer is I can't remember. Okay. Uh okay, that's all that I can explain from the picture.
Okay, so can you see that? Well, it's important to know that once there's the effacement of the podocytes, then you aren't really able to see, or there'll be poor visualization of the slit diaphragm, which is, I think, the third layer that you were talking about. So what that does, do you want to go on? Once there's effacement of the podocytes, what
When
happens?
the okay. Okay, then yeah, you can.
Correct. Okay, so when there is the effacement of the podocyte, they will change the ionic changes. There will be ionic changes in the global GBM, glomerular basement membrane. So that it will allows negative charge like albumin to enter the filtration,
Mm.
and also it can also one other theory is the hole is become bigger, so more other like proteins can also enter the GFR.
Yes. So it can albuminuria will definitely happen, and that can hematuria can be yes or no. It depends on how bad it is. Mostly no, no? Through the same mechanism. I mean. Okay. Next.
Can I ask the picture B and C is taken from
Can
what modalities?
I took it from the NHS website.
Is it a tissue histological?
It's an electron microscopy image.
All right. Thank you.
Can you hear me, Dahya?
Yes. Thank you.
It's an electron microscopy image.
Can you?
Okay, so this is a picture explaining one of the complications. It's uh, self-explanatory, but can someone explain as well, and then the answers will show? Any volunteers?
Then together with the proteinuria, there will also loss of an anticoagulation factor, commonly antithrombin 3, protein C, and protein S that cause the procoagulant to be relatively high. Means that
Yeah.
the blood is more thicker
Mm-hmm.
and in hypercoagulation state.
Okay. So can you click, Afika? So this is the thrombotic abnormalities. As Nadi said, there will be a loss of low molecular weight anticoagulants because they will be following the proteinuria. And then they will, with that, there will be increased levels of procoagulants. It's important to know that there can also be hepatic overproduction of protein in response to the hypoalbumin because the patient is continuously losing albumin, right? So because of that, they will be in a hypercoagulable state, and that can predispose them to have a thrombophilic state or like present with thrombosis. Okay. So this is just a summary of the findings that you can have for your own reference. So the important thing to note in this slide is that thrombosis can cause a lot of findings that can vary from respiratory distress and tachypnea to hematuria if there is renal vein thrombosis, and seizures if there's cerebral thrombosis. Okay, this is just a slide trying to differentiate between nephrotic and nephritic for my own reference. Okay, thank you.
Thank you also. Okay, I think now we got the message about importance of OSCE. Until few days, inshallah, you can start to go and see the patient. Hopefully, inshallah, next day will be assuring like our days, inshallah. We got about 10 minutes from the second presenter. Can we start with the second case, please?
Yes, doctor.
Who will be?
I'll be the patient and Afika will be the doctor.
Okay.
Can everyone hear me? Okay, so Assalamualaikum. My name is Afieqah. So, what can I call you?
You can call me Hanani. And
Okay.
I got my child with me, named Hafiz.
Okay, so Madam Hanani, what brings you to here today?
Okay. I came to the hospital today because my child complained of abdominal distension. Okay. For the past 3 months.
How old is your child?
My child is currently he is 6-year-old.
6-year-old. Can you tell me more about the abdominal distension?
Okay. Initially, I didn't notice it at first. Since the abdominal distension is not that prominent, since when the child is chubby as well, so I couldn't really notice it. So eventually the abdominal distension is started at 3 months ago, and then it progressively increased, like worsening, like it become more prominent. Okay. However, my child did not complain of anything about this since it is a painless abdominal distension.
Mm-hmm. Does he have any other symptoms other than the abdominal distension, such as he complain of pain, abdominal pain?
I think for the past 3 months, yeah, I noticed that my child, he became like he looks lethargic, like he become easily tired when doing like playing activities with his friends. And then he also like like when I ask him to eat, like he doesn't want to eat. Like he reduced in eating.
Also, his eating habit become less than usual.
Yes.
Does he have any other complaint?
Complaint, I think for the past 3 months, that's the main complaint. However, that I noticed recently, my child, he is actually like sometimes there are bruises on his body, but it just like a rare occasion, like sometimes, but it is off. But it comes and go, the bruising.
Mm-hmm. So where do you notice the bruises?
So the bruise size actually at the uh it can be like at the upper limbs at sometimes at the yeah, okay.
Um, uh, is there any bruises at the leg?
Like I didn't really notice it at first since the breathing like it comes and then go, so like you need to look at the chart thoroughly to look for the bruises. So it just like among the for among the past 1 month, like there's a few occasions like the breathing is at the different size. So sometimes at the lower limbs and sometimes at the upper limbs.
Mm-hmm. How about the size of the bruise? Is it big or small bruise?
It's just like about the the 10 cent coin, like 20 cent. It's about that size.
Mm-hmm. So that does he have for the past 3 months? Does he have any nose bleeding? Nose bleed?
There's one occasion that he got a nosebleed, which is last week.
Mm-hmm.
It's just a sudden occasion, like he got nosebleed. I don't know why. However, it stopped.
Does he have any like swelling? Swelling in the knee? You notice
So no,
any swelling
I
in the
didn't
knee?
notice any swelling in the knee.
No swelling in the knee. So
Yeah.
is there any uh, family member who had any disease, blood disease?
Uh, eventually, he got a brother, uh, and then his brother died at the age of 5 year old. However, I'm not sure about the exact diagnosis that at that time of why his brother died at that 5 years old. However, his brother got fever at the 5 years old time, and then he
Mm-hmm.
passed away. I'm not sure about the diagnosis.
Okay. Do you notice that your child look pale?
Pale. Yes. He looks pale and easily tired.
Mm-hmm. How about his activity?
What about?
Activity. Does he play like usual?
No. Since for the past 3 months, like he complained of fatigue, like easy tired, so he don't really play with his friends.
Does he has a complaint about bone pain?
Currently, there was no complaint from him. Uh, no.
Do you notice is there any change of his behavior?
Behavior, no. This no. It just that he like quiet than usual, like easily tired. Just that.
He doesn't
Oh,
behave weirdly.
no. Oh, I forgot to mention, like, for the past 1 year, like, I noticed that my child frequently getting fever, but I thought it just children tends to get fever easily. So I
Mm-hmm.
can take care of it. She always got fever, like, once a month. Just like, and then resolve.
For the past 1 year.
Yeah. However,
So
it
he
got once a month.
so he had been sick for every month.
Yeah.
So how about currently does he have any fever?
Currently, no fever.
Okay. Uh, that, do you notice if your son has lost some weight?
Yes. For the past 3 months, that since I said just now that my son is just in like eating, so I noticed that he like a smaller compared to his body size like for the past 3 months. So the weight that I noticed that it went down from the 23 kg to 18 kg.
So about regarding the reduced feeding, does he say that he doesn't want to eat because of he doesn't have a appetite, or he doesn't want to eat?
I'm not sure about that. He just doesn't want to eat.
Okay. Is there any do you notice that he has drenched night sweat at night
Oh,
when he's sleeping?
I'm not sure about that. Sorry.
Okay. So does he have recent like throat infection?
He never complained of me like having sore throat.
Okay. Does he complain any joint pain?
No, he doesn't complain any pain currently. But I brought him here because I was too worried since he got like nosebleed last week, and then like his condition become worsened for the abdominal distension.
Okay. Mm, um, do you have any history of jungle trekking
No,
before?
no.
No. Does he taking any medication?
Currently, no.
No medication. How about uh, is this his first time to hospital?
Um. Yes, this is his first time coming to hospital.
Before this, he had no
No admission.
medical illness or admission.
Uh,
So does he have any surgery in the past?
no.
No. So does he have any food or drug allergy?
No.
How about his birth history?
For the birth history, uh, what do you want to know?
Do you have any problem during pregnancy?
Oh, I'm healthy during pregnancy, and my child was born when he was 37 weeks.
Mm-hmm.
So, okay. And then
How about
he's
his weight?
healthy. Uh, his weight it is 3 kg, and
Uh,
he was well until for the first like 1 year, like he got fever, like, and then
mm-hmm.
for the past 3 months, like I mentioned just now.
So for the does he have so he was born through
Normal,
normal delivery.
normal delivery.
Does he have any jaundice
When?
after
Uh,
delivery?
oh, yeah, he got jaundice, but for just sometimes like usual, but less than 2.
Okay. How about his immunization history?
He take the vaccine up to his age. Kan?
Completed vaccination.
Yeah.
How about his development?
Oh, but what?
Development.
Uh, he do well in his study. Like just like the other child. He got no problem to study. Like he can read. At the 6 year old currently.
Okay. Does he go to school?
Yes, preschool. He
So how
he
about
play
his
with
school
okay.
for the past 1 year?
For the past 1 year, since I complained that he got a fever, so like when he got a fever, so he missed some days for in the past 1 year, like few days in a month for his school. However, he can catch up with like he's okay. His studies still okay. Uh,
Um, How old are you, madam?
I'm 35.
Well, how about your husband?
35 also.
Both of you have any disease?
No.
No. How about his siblings?
It's something that I mentioned just now, like one of his brother, like passed away at the 5 years old, but I'm not sure about the reason. And at that time, he presented like this figure. And then like I got four child. So the one passed away at the 5 year old. So currently the second child, he is the second child, 6 year old. And then I got the other child, 4 years old and also 2 years old.
So the other are healthy?
Yes, the other are healthy.
Do you have any family history of cancer in your family?
Like I think his grandmother got like I think cancer, but I'm not sure what cancer, like it like blood cancer. I'm not sure like which type of the cancer.
Does his father smoke?
Yes.
Does he smoke inside or outside the house?
Usually he smoke outside of the house, away from me and my child.
How about your household income?
Or for my husband and also I. So it is about 5,000 per month.
So what both of you do?
Oh, we are both teachers. Anything.
I think that's all from me.
Do you want to what system will you?
You got
So
4 minutes.
So okay. So does he have complaint of any other swelling elsewhere?
No swelling. Apart from the abdominal distension.
No neck swelling, no inguinal swelling or testicular swelling.
No. I didn't notice any swelling on his body.
Does he complain any shortness of breath or chest pain?
No.
How about his urine and bowel output?
His meat bone output was normal, like as usual. But since he reduced in eating, so the bowel output become less frequent.
Is there anything that I miss?
Okay, so can you make summary now?
I'll try, doctor.
You have a very cheerful patient. Okay.
Okay. So my patient, Hafiz, 6 year old. with no non-medical illness presented with complaint of abdominal distension for 3 months duration. It is a painless abdominal distension, and it is gradually increasing for the past 3 months. It was also associated with lethargy, malaise, and also constitutional symptoms such as loss of appetite and loss of weight. 5 kilogram, and then it was also associated with epistaxis and also easy breathing. His mother also complained that he had easily to get infection for the past 1 year. Otherwise, there's which is recurrent fever. Otherwise, there is no night sweat, no history of pharyngitis, no history of jungle trekking, no history of drug or medication use, no joint pain, no bone pain.
So what is your working diagnosis?
So my provisional diagnosis for this patient is, I think it is acute leukemia, because patient presented with acute symptom and recurring infection, constitutional symptom. Patient also complained of his mother also complained of pain.
Other differential diagnosis?
My differential diagnosis, I would think of lymphoma, but this patient only has history of fever, but no history of has history of fever and also loss of weight, but no history, but no night sweat. And then I will also consider infectious mononucleosis, because patient has current fever, but and also complaint of lethargy, but he did not have any history of pharyngitis.
So what can be the cause of abdominal distension in case of lymphoma or leukemia?
So in acute leukemia, if there is presence of abdominal distension, I would suspect hepatosplenomegaly due to infiltration to the organs.
Okay, so what other differential diagnosis of hepatosplenomegaly?
I didn't get that.
Other differential diagnosis of hepatosplenomegaly.
Hepatosplenomegaly. So I would like to divide it into hematological cause and non-hematological cause. So for the hematological causes of hepatosplenomegaly, it can be leukemia, lymphoma, myeloproliferative disease, pernicious anemia, and also sickle cell anemia. And for the non-hematological disease,
Sickle cell only? You are non-Malaysian? Are you non-Malaysian?
Hereditary thalassemia.
thalassemia.
So can this patient be thalassemic?
I don't think so, because if patient is thalassemia, he will present during after first 6 months of life because of the conversion of the HbF.
Yes. Okay, other causes of hepatosplenomegaly?
So the other causes of hepatosplenomegaly for the non-hematological cause, it can happen in chronic liver disease with portal hypertension, in infectious cause. It, for example, is infectious mononucleosis by Epstein-Barr virus, cytomegalovirus. Other causes, infiltrative causes such as amyloidosis or sarcoidosis. Others, such as in chronic connective tissue disease, SLE.
Okay. So, what is the investigation you are going to consider now?
Mm-hmm. So the first investigation that I would like to do is full blood count with full blood picture. Because my provisional diagnosis is leukemia, so I would like to look for evidence of anemia and also thrombocytopenia due to bone marrow infiltration. And also in the full blood picture, I would like to find the blood cells, presence of blood cells. Mm-hmm.
What is the normal for blood cells?
Pardon, doctor?
What is the normal count for blood cells?
It should be less than 20%, if I'm not mistaken.
So you miss about 80% of ALL. Okay, who can answer? Another job. Who can answer?
I think for normal bone marrow, but to diagnose more than 50%. I'm not sure. 50%.
Okay, who will do the full blood counts and who will do the peripheral blood film? Both of them, please speak about before the full blood count. Now I need someone to make specific for blood film, what we must look for. Okay?
Okay,
two homework now. Okay? And must be shared to the group within, inshallah, 72 hours. Okay. If this patient has thalassemia, what you will see in the peripheral blood film? Just to memorize you, if you are living in any area, you must know from A to Z about the most common communicable disease or prevalent disease. If you went to Europe, you will find them speaking about cystic fibrosis, about that. If you going to America, you will find them speaking alpha-1 antitrypsin deficiency. Every area has its own disease. It is not wise to forget it because it happened.
I answer
In the exam in front of us, really the patient has mongoloid feature, has delayed growth, he has hepatosplenomegaly. And when we ask what is the diagnosis, the candidate insists number 1, leukemia. Are you sure? Yes. So please don't forget, it is the same if you got any patient with fever. You must rule out dengue because it is the most prevalent disease, okay? Yes, what do you need to ask? Do you need to ask or comment?
from dengue prone area, fogging activities.
Yes, so it is very important. Okay, so you must know that issue. It is very important. And you must know all the details about that. If it is thalassemia, we must know what will be present in the peripheral blood film. Okay, what other investigations?
So for special investigation, I would like to do bone marrow aspiration and refine biopsy.
Yeah, so you must ask yourself always what is the index sum investigation. Okay, so it is the bone marrow. Okay, but if it is thalassemia, it will be
Electrophoresis.
yes, which is known as hemoglobin study. Usually, if we start by anemia, we will make iron study. If we come to hemoglobinopathies, we are doing a two hemoglobin study, which is electrophoresis. And what else? Gene study. Very important to go for genetic study. Okay.
For genetic study, is it the HB-DNA? Is it the same?
Yes, yes. They are speaking. They are considering it in many situations, especially for alpha thalassemia, which is so rare. Sometimes the beta thalassemia major and like that is easy to be picked by hemoglobin electrophoresis, but other rare types you may need to do that test. So, mom, we come back to the mother.
Yes.
What is the diagnosis of your kid in that presentation?
Acute lymphoblastic leukemia. Yes.
Okay, ALL.
Yes.
How ALL can affect the child?
How?
Yes.
So eventually, ALL usually it presented with non-specific symptoms. Just like you see just now, like fever, easily fatigues, and I finding that I couldn't understand how it affect the child in what aspect.
Yes. ALL, it will affect the bone marrow. And how many series of cells we have?
Oh, we have B cell and T cell.
Yes, RBCs will be presented by anemia. We have white cells. It can be increased or decreased. In all situations, it is susceptible for infection. It will affect the platelet, will get some bleeding. So every component of the bone marrow will be affected. Okay, and this degree of affection can give us a prediction of the severity of the disease. It is very important. That's why if we ask about the investigation, yes, we can ask for bone marrow and cytogenetic studies. Cytogenetic study is very important, please. It will help us to define the type, what is the best treatment for that type, because now oncology became very advanced. Okay, it is not just sometimes they can go for bone marrow transplantation, sometimes they can go for some rare immunological drugs like that. So it is very important to consider cytogenetic study. Okay, at least we must mention for that. But generally, we must rule out the prevalent disease in the community. Okay. A very important point: if you found any child with loss of weight, you must be very cautious, especially if he crosses a centile more than 2. Cross more than 2 centiles. Suppose he is in the 9th centile. I found him now less than 50. It means he crossed the 75, he crossed the 50. Any child crossing more than 2 centile must be very cautious. Okay. The second thing, which is very important also, if the child behaves not normal, usually child must be running, playing, cheerful, active. If you find the child is not like that, you must take care in your practice. Okay, so this is very important. So please, causes of loss weight or failure to thrive, okay, must be taken seriously. If you found any patient with loss weight, yes, we consider hair leukemia, but what other cases which can cause weight loss? Generally, we see it in the, especially if the child eat well and lose weight.
Malabsorption.
Okay, what else?
Hyperthyroidism.
What else?
Infections such as primary tuberculosis.
Tuberculosis will cause loss of weight, but usually he has loss of appetite. So the patient has good appetite or increased appetite with loss of weight. Number one is
gastroesophageal reflux.
no. Oh, that is the issue.
Parasitic infections.
Sorry?
Parasitic infection.
Can be considered as parasitic infection, but the number one is diabetes mellitus. Don't forget, if the child eat well, lose weight, you must ask him about what about urine, when frequent urination. So we are going now to diabetes mellitus. He said, yes, I am irritable and his eyes are a bit exophthalmic like that. You must expect it can be hyperthyroidism. So it is very important in our practice. We have some known as flag signs. If the patient lose weight, I must be very cautious. I must be broad-minded to expect anything. Now I can expect in this patient he has what is this leukemia. Sometimes I will find him with diabetes mellitus, with hyperthyroidism. Sometimes I will find him with end-organ affection like chronic renal failure. Just he was given a strong course of antibiotic and started to put renal derangement and is complaining of abdominal pain and labile hypertension. So it is very important to concentrate on that, please. Okay, child working with childhood, it needs us to be very alert. They are not speaking, and sometimes the family cannot notice everything. So if the doctor has no good observation, it will be a big problem. That's why they sometimes put the pediatric doctor like the veterinarian who must diagnose the animal without speaking. You just get a look and they can diagnose. Sometimes the same thing considered for pediatric. He cannot tell you the truth, and the mother sometimes tell you expression or expectation or her afraid, not actual observation. Okay. ALL and the differential diagnosis of weight loss, differential diagnosis of abdominal distension, mainly for hepatosplenomegaly. Okay. Recurrent fever and immune deficiency must be put in our plan. Okay. So all this give us, thank you for that case, a broad spectrum how to deal with pediatric patients. PEDS is open book. You can go everywhere and you must suspect everything. And without high index of suspicious, you can miss a lot of diagnosis. Who will present the Oski?
Me, Dr. Farhana.
Okay, so hoping you can take 10 minutes so your colleague can get 5 minutes for their questions.
All right.
Okay.
Oops. Right. So this is the first OSCE. Describe the finding, possible diagnosis, and investigation. Anyone would like to volunteer? Anyone?
There's
All right.
there is a abdominal distension,
Okay.
and then there is a mark there, maybe indicate a mass, I guess. And based on the shape, I would guess that it's maybe hepatomegaly, possibly based on the shape that it drawn there.
Mm.
Uh, my possible diagnosis would be hepatomegaly, but I need other features to actually make a definite diagnosis. And my investigation, I may suggest for abdominal ultrasound,
Okay.
maybe.
Okay. For your diagnosis, what's the possible diagnosis? Sorry. Hello? Can you hear me?
Yeah.
Did you answer? I didn't hear the possible diagnosis.
The possible diagnosis, I just see that it's hepatomegaly, but I could not like pinpoint.
Any ideas onto what it could be?
Mm, I'm not sure.
All right. I mean, we discussed it just now, so it can be any of the causes listed by the presenters just now. You want to try, Nadine?
I'm sorry, maybe leukemia, but then I need other features to actually suggest that diagnosis.
All right, cool. All right. So I'll go to the answer. So the finding is abdominal distension due to hepatosplenomegaly. Possible diagnosis, with it's been explained earlier, can be due to infectious causes, hemolytic causes, nutritional causes, leukemia and lymphoma. So the investigation, it can be you can do full blood count, full blood picture, to rule out whether it's a blood-related cause, and bone marrow aspiration and trophine biopsy. Also chest X-ray for the example for leukemia, where there can be a mediastinal mass, and then the rest are mostly to see for any complication of the disease.
Sorry, come back again, please. The most important when seeing a patient like that, before rush for investigation, rush for clinical signs. Please, then believe. You must said, I would like to go up and look for the face. It may be the face is mongoloids, okay, with features of thalassemia. It's okay because this is the most common scenario here. The patient, as you can see, has hepatosplenomegaly. It is both sides. It is right lobe of the liver, left lobe of the liver, and to the left of this, there is another enlargement of the spleen. So number one, try to go and look up. Is there any mongoloid features of thalassemia? Is there any jaundice? Is there any failure to thrive? Is there any delayed puberty? Is there any here in the abdomen, is there any puncture site for deferoxamine? All this is your business. Before the lab, please. Always start by yourself. So your clinical sense is your future, not the lab. Sometimes the lab can make wrong investigation or give you longer time to give you the result. You must be able to judge the patient clinically, okay? Maybe portal hypertension, especially if there is veins here, you must know what is the direction of the blood. Is it from up to down or down to up? It's very important by just clinical observation and the clinical skills, okay? Okay, next.
All right. Okay, you can read this later. Okay, next question. Describe the finding, diagnosis, and investigation. Anyone would like to try?
So for this picture,
Sorry?
for this picture,
Okay.
there is multiple swelling at the right neck.
Okay.
It looks around in shape
Mm-hmm.
with no skin changes.
Mm-hmm.
For the possible diagnosis,
Mm-hmm.
it could be infection such
Mm-hmm.
as tuberculosis,
Mm-hmm.
cat scratch disease, or viral infection such as EBV or HIV.
Okay.
It can also be autoimmune such as SLE
Okay.
or drug-induced, and also can be malignancy
Mm-hmm.
such as ALL, lymphoma.
Mm-hmm.
So for the investigation, we would like to order for blood culture,
Mm-hmm.
and then virology.
Sorry?
Virology.
Viral serology. Okay. All right. Okay, good, very good. All right. So there's most likely there's a cervical lymph node enlargement at the supraclavicular muscle. So possible diagnosis can be lymphoma or any of the diagnoses that Afieqah mentioned earlier. So the investigation also, as Afieqah mentioned, and also as Dr. mentioned before, we should go to the clinical signs first, and then we can investigate using lab work, whether it's a full blood count, full picture, ESR, also at the viral serology, excision and biopsy, and also do chest x-ray. Okay. Doctor, would like to add anything?
Yes, please. Again, thank you for insisting for searching for other clinical. Of course, the history can give us about 70% of the details. Our clinical sense can give us up to 25, and the remaining will be for investigations. Okay, so asking the history, how long is it? It may be short time, long time, because the comment can guide you. If it is just recently, okay, I will ask for that. What can be, is it infection or other? If it is long term, what about the other symptoms? But even after all this, no negotiation about that, but you must comment about the lymph node itself. How is the size? How is the consistency? Is it matted or not matted? Is it attached to the skin or attached to the underlying? So your hand is your skill. If you try to catch the lymph node and see it is multiple lymph node collected here together, it is matted lymph node. Oh, matted lymph node. If I go to the Mr. Google, let me take care about GP and the other. If I found it firm or solid, oh, he will tell you take care. It can be malignancy. If it is adhesive to the skin or underlying structure, it is like that. If it is in the right side or left side, it can be affected. Sometimes the TB in the area of vaccination can cause some lymphadenitis in the same side. So your clinical evaluation is very important. And I am trying to advise everyone, don't sell your clinical sense to the lab, but you will make the lab confirm your clinical sense. This is different. To do some doctors, and sorry for that, can be of the type of blanket investigation. I will ask for everything. Now we are for teaching, you are mentioning everything. But in actual life, you must come to the first one top diagnosis. and try to do investigation. If you failed, you will go to the second one. If you failed, you will go to the third one. It is so bad to do for the patient 100 cycle until you came to the conclusion. Okay?
Yeah.
Okay, thank you.
Okay, the next one. All right, so the boy with recurrent infection and hepatosplenomegaly. Okay, describe picture, diagnosis, and poor prognosis factor. Okay, who like to volunteer for this
I want to try.
one? Okay.
So according to the picture, this is pictures of blood cell with scanty cytoplasm and large nucleus within. So for the diagnosis, it is leukemia, specifically acute lymphocytic leukemia (ALL), and it has poor prognostic factor in if the patient has Philadelphia chromosome in boys, and if there is any presence of CNS symptoms. So
All right. Okay. Can you guys see it? Okay, so yes, there's a lymphoblast with scanty cytoplasm, and actually there's some vacuole, and also the diagnosis can be ALL. So poor prognosis factor, as mentioned before, boys, TLL in children, Philadelphia chromosome present, and also if there is CNS findings. Okay. Doctor, would you like to add, or I just go next?
Okay, continue.
Okay, I go next. All right. Okay, so this one is a diagram. So after chemotherapy, all right. So what syndrome is this? What are the clinical findings and treatment of condition? All right. Anyone would like to volunteer for this?
Hemolysis syndrome.
Mm-hmm. The clinical findings?
Nausea and vomiting.
Okay.
Diarrhea. Muscle cramps.
Okay.
Weakness.
Okay.
The treatment mainly hydration.
Mm-hmm.
That's all diagnosed.
All right. All right. I'll go to the next slide. Yeah. All right. So yes, acute tumor lysis syndrome. So the clinical findings are based on the problems which the patient face because of cellular breakdown from chemotherapy. So there will be hyperuricemia, hyperphosphatemia, hyperglycemia, and hyperkalemia. So the patient can get renal failure, cardiac dysarrhythmia, and neuromuscular irritability. So the symptoms and signs are what Afika mentioned earlier. Patient can get cramps, tetanus. Patient can get cardiac dysarrhythmia, and also because of renal failure, there can be oliguria. All right. So the treatment of the condition. So this is from PEDS protocol actually. So there's prevention and also treatment. So it's very long actually. So yes, true. We must hydrate the patient. But if the patient does get this syndrome, and some of the management can be to treat the problems that the patient face, such as hyperkalemia. If required, we can give them diuretics and treat the hypocalcemia. And also, if we need it, definitive treatment is to do dialysis. All right. Doctor, would like to add anything?
Yeah, remember that sometimes the hemolytic uremic syndrome can occur even before start treatment because the overload of the malignant cells. So you must be cautious. Even if you just diagnose the patient, do it. Of course, the treatment can precipitate it, but you must be cautious. Okay?
Okay.
It is very important because any over destruction of any part of the body, it can cause tumor problem. Okay, like tumor lysis syndrome. There is like nowadays with the COVID, we can hear about immunological activation and of the body. All this has a very bad effect. Okay.
Okay. Right.
Okay.
The next one is another photo. Does anyone want to volunteer?
I would like to answer.
All right, Annie.
So, the picture show a red stem blood cell, which is when we found this kind of picture, the diagnosis will be a Hodgkin lymphoma. So for the clinical features for lymphoma, so usually offers similar to the presentation with leukemia. However, it got a B symptoms, which is consists of fever, night sweats, and also cause loss of weight.
Okay. All right, good. All right. Next. Oops. All right. So betul, red stem blood cells usually in Hodgkin's lymphoma. So the clinical features, usually there's a painless lymph node enlargement at the cervical or mediastinal area, and it can be at the extranodal sites as well. And betul, can get B symptoms as well, such as fever, night sweats, and weight loss. All right. Okay, that's it for me.
Good. Yeah, it is good to offer us a lot of varieties for Hannah. Thank you.
All right, welcome.
Well done. Now it's your turn if you need to ask any questions, please.
Doctor, I have one question. Basically, it's about the previous case. So from what I understand, the child have a relapse event when the steroid tapering therapy. So can we consider it is a steroid dependent nephrotic syndrome in this case?
Yes, of course. Sometimes it will be looks like overlapping. Is it steroid dependent or steroid resistance? Okay, but both of them I think must be considered for renal biopsy. If you cannot taper from steroid, also it will be considered. Okay, but sometimes at the start you will say it is steroid dependent. You cannot win. After that, you can come to the conclusion, no, it is resistant with time. So it is dynamic because the immune system is the one which is working. Sometimes it will not come to the lone picture at the early time. That's why we are giving about up to 14 up to 28 days to see if there any response or not. So we are giving a chance in spite of steroid. If you give someone just injection of steroid, it can modulate his immune system rapidly. But you are giving it for up to 4 weeks to see the response. So it is accepted area of hazy, not yet able, is it steroid dependent or steroid resistance or like that.
Okay, doctor. So for indication, the renal biopsy for this patient is slightly due to the maybe possible gross hematuria or the frequent relapse.
Usually it will be very clear. Frequent relapse with intermittent hypertension with some hematuria and some like nephrotic. You cannot define which is which. Complement. All this usually will find mixture for every patient.
Okay.
That give you, but the decision for renal biopsy is related to the nephro specialist. Okay. Even if you are referring the patient, you must tell them only, I need the opinion of subspecialty. They may consider further investigations like that. Because it may be he need to try another regimen like that first. And most of the area prefer, if you refer the patient. So will be responsible once he came to kidney biopsy, he is responsible. All of you must read about the what we can see in the kidney biopsy, how many types, okay? It is very important also.
Okay.
Okay. Thank you. Is it tomorrow also our second meeting?
Yes,
Yeah.
Is it okay for you, or it is condensed course now?
It's okay.
It's for you. It's for you. For me, I can handle if you wish. But try to to put two different systems. Good today, our system looks the same, but it is very important to try to change it to system in the same setting. Okay.
Okay.
Okay. Okay. See you, inshallah, and hoping the best for you.
Inshallah.
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 Assalamu alaikum.
Salam. Thank you so much, Doctor.
Thank you, Doctor.
You are welcome. You are welcome.
Thank you, Doctor.
Okay.